us to make this happen. It was a big change for tinnitus sufferers. Thank you.
Thank you very much. Would you like please to join me here, and I will invite our other presenters from this morning, so Louise and Rosalba, to come back here with us. Paula will be joining us online. And Rosalba, of course, if you would like your colleagues to intervene, you're very welcome to give them the floor as we go through the discussion. Yeah, here's Louise as well. Hello, Paula. Welcome back. Happy to see you're holding the fort, even if you must be absolutely exhausted at this stage. So, first of all, do we have questions in the room? I'm sure following these four very interesting presentations, there must be... Yes, we have a question at the back there. We have none online yet.
Thank you for the fascinating, really, presentations. I enjoyed very much this morning. So my question to Paula about, your stratifications, because, as far as intersectionality matters, I thought that it's maybe important to include ethnicity or immigrant status in your analysis, but I didn't see that because previous analysis showed that there are intersections between, ethnicity or nationality or immigrant status and socioeconomic status. So I thought that this could be an important to have included this analysis. And a question to you, Christopher, about tinnitus. Do you know that if the brain adapts at a certain point to these voices or not at all, if you have studied this? And then, from friends, I know that sometimes listening to certain music and alternative medicine could help. Can you tell us about this? Thank you.
Thank you. So maybe Paula?
Sure. Thank you so much. I think that's an excellent question that you brought up about these different intersections and the idea of things like ethnicity and immigration status. We would love to be able to include that, but the data that we had just didn't have a lot of those variables there. It's the sort of thing that we think is really important to include because as you have more and more of that information, you just learn about pieces that you really don't know. But that was one of the struggles. Some of the data sets we had would have things about marital status. Other data sets would have something about socioeconomic status. And another one had pieces around, educational attainment. But it was all very hit and miss. It's not being done in a sort of a planned way. And so I guess, going forward for research, one of the things we're talking about is if you're interested in gender and things that might be some of those key intersections, we need to purposely make sure that people are including it in the research. It's a great question.
Thank you. Christopher,
yeah.
the brain adapt?
Well, in fact, I could answer the other aspect also about immigration.
Please.
Because we've seen, we haven't published the data though, because it's very hard to interpret, but we see greater prevalence of tinnitus and severe tinnitus in those that are immigrated in Sweden. So is it specific to Sweden? Personally, it was a culture shock when I went there. But this could be a phenomenon that happens to any person going to another culture. So it requires validation in other countries and so on to better assess also what's the underlying assumptions there. With regards to your question about the adaptation, this is what is complicated with tinnitus, is that there is no correlation between the perceived loudness and the severity. That means that some people can be annoyed by a fly that is in there in the corner of the room, and some just ignore it. And the distribution of that is quite unclear. But since severe tinnitus is genetically influenced, what we believe is that some parts of the brain that we call that a gating it puts a brake onto some sensations. For some people, that brake might be broken, so there is increased activity in the brain, and this is what we're investigating. With regards to treatments, as you say, some people use noise to mask it, but it's not recommended by the EU guidelines, because we see that for 1/3 it works, for 1/3 it doesn't, for 1/3 it exacerbates it. It makes it worse. And this is in fact a trend that we see for many of the different types of treatments, and we yet do not understand why this is like that.
Sorry, we need you to use the mic, because otherwise people online do not hear you.
So for alternative medicine like yoga, mediation, all these kinds of things, does it help, or you did not study?
We don't consider these as good study designs because you often lack a control. So it's not a proper, it's not a randomized, blinded control study. So we cannot give recommendations on these.
Okay, thank you.
That's a problem.
Thank you.
So we had a question from Bilkis, and then a question from the lady at the back.
Thank you for the excellent presentations, everyone. Chris, my question is for you. I want to build on the one that my colleague just asked and that you answered about population in their diversity. My preoccupation, is like we have an amazing group in the global north. The issues sometimes may look like, and with all due respect, may be like a luxury sort of symptom, but I don't know if that's the case that you have seen. And I say that because I think in the global south, that probably is not even diagnosed. So do you have any sort of recommendations for, and you said that, you need more studies, right, to apply it in the south, but how do we sort of go about, my question is like, how do we go about raising awareness that it happens and it exists and you can consult, because you're saying that just by consulting it helps some of the women you've seen. So I'm just thinking in terms of a longer term application, maybe we can increase awareness, the tinnitus literacy to some extent in a diverse sort of population, and I don't know if it's possible. And to that, and then my quick second question was the gender, the concept of gender, if you can just reiterate how you sort of defined it for that study.
So when you mention luxury in the north, what are you referring?
I don't even have, in other words, it's like, I have so many other issues to deal with. Like I don't have enough accommodation, I have to go to the farm, I have to raise the, chicken, kids, and, I don't have a health post when I'm pregnant, so I don't even think of having this noise being a problem, is what I was saying. Like where you're in a country where, once, that's what you're saying, that when you migrate, then all of a sudden, you realize that you have issues that you didn't even know there were issues. Because we know that a lot of, like it has been studied that, some of the immigrants who declared they were healthy, then ended up, having discovered that, people have, back pain. Maybe I'll go and declare I have a back pain.
No.
Which was not a problem when I was in my country of origin.
Yes. That's a complicated thing because we've seen that the guidelines vary a lot between countries. And not everybody uses the same type of definition also for tinnitus. And the majority of the people that suffer from it, they know there is nothing to be done. So there is the kind of dogma that any doctor would tell you, you have to live with it, there's nothing there. So eventually in Sweden, as you say, there is a path where you can get some care. They use the standardized tinnitus questionnaire to score it. In the south, this is not as frequent. We've seen in our European studies that there is a gradient of prevalence, so it's much more prevalent in the north, even more so on the east. So this is a strange pattern, but we just conducted a case control study in Italy where we showed that Italian diet prevents tinnitus. So eventually, being in the south gives, greater wealthy food that has some impact in how it can be developed. Question mark.
So we had a question from the lady at the back there. If one of you would like to add anything to, I mean, not necessarily to Christopher's point, but
in our study we administered a questionnaire of adherence to the Mediterranean diet, just to have the correlation between this kind of the food and the macrobiota. But we can explore if this is related to the occurrence of adverse events too. Of course, it could be because it's related to inflammation levels.
Yeah. The unfortunate thing about these things is that with the study that we performed in Italy, we cannot replicate really in Sweden because the diet patterns are so different. So if you have tomatoes and mozzarella in the south, in Sweden you get herring and
Thanks very much. I'm sorry, Chris, I'm going to keep you in the hot seat for a little bit longer. I just had a quick question as a follow-up to what you were saying about auditory gating. Have you seen any overlap with the cohort that you studied and neurodivergent individuals who usually, would commonly have this hyper-auditory experience? Is there any overlap between the patient groups?
we haven't seen that. No. But good question.
We have received a question online in the meantime, and I'm afraid it's again for you, Christopher. So,
Fun tinnitus.
yeah, we hadn't had a call for funding yet today, so we need one. We had a few yesterday. We need to continue putting pressure. So, Christopher, the question is, regarding the lower suicide risk in women who were seen by a clinical specialist, were you able to exclude factors such as health-seeking behavior in those women who sought help, or is access to specialists an issue?
Very important. We wanted to do that analysis. We couldn't do that because it was not available in the data. Access to care, I think that in Sweden you could say at least the population we evaluated is in the Stockholm region, and we have some representatives from the Karolinska Hospital here, and they could say that. Whenever you go to the GP, and that's the first step you have to do in a country where you have social healthcare system like Sweden, then directly you have some guidelines that say, all right, you have to perform this questionnaire, and if you score high, then you go to specialty care. And if your score is a little lower, but you have great anxiety and stress, then you're referred to that care anyway. So I'd say it's pretty equal for people in that sense. Now, seeking behavior, this is something that would have required more type of societal study that we haven't performed, but it's a very important question.
Okay, do we have another question in the room? Because I have a couple of questions as well. So while you think about, I don't see any raised hand, while you think about what you would like to ask, I have a question which actually can target all three of you, because the GenderNet Plus projects and the results we've been hearing have really highlighted the need for everyone to focus on intersectional variables and the quality of life measures to help us discover the inequalities between male and female patients. So on the basis of these results, we could certainly plan certain types of intervention and implement them to help reduce those inequalities. And in that case, what strategies do you recommend to better capture the impact of gender medicine interventions? And should the strategies be incorporated in future research projects? Should they be specific aims for these research projects? So, Rosalba, yes.
Yes, just can suggest some design like effectiveness implementation trials that are, of course, evaluating the efficacy of interventions. Like, for instance, in our case of our project, we could plan if we have seen some differences in psychological effects and quality of life effects. We could suggest to patients that we can select a priori before before starting the intervention to go to psychological counseling, for instance. And this kind of study design is called effectiveness implementation trials, and they are evaluating the effectiveness of medical or clinical intervention, and also they are collecting what the operators and also the patients are the perception of the efficacy of this kind of intervention. And of course, these are used also the questionnaires administered to the operators and the patients too during the trial. So we could implement such a kind of clinical trials in which the outcomes are both efficacy outcomes and also the efficacy of intervention as measured by operators and patients.
Louise, what strategies?
Well, I think that we've heard so far that gendered factors affect health. I think we all agree with that. Some of the factors tend to affect women in a deleterious manner more than men, so we kind of agree on that. But the way we provide care right now is very like the biomedical model, mostly drug-related and all that. And then even in predicting outcome, we have tons of predictive models that are used by clinicians at the point of care, and none of those models incorporate the gendered factors that will prevent, patients from benefiting from the drugs you're prescribing, or, the diagnostic tests you're prescribing. So I think moving forward, the intervention is to, certainly sensitize, the medical community. This is about health this morning, of the importance of gender-related factors, and also find ways to incorporate it in care. For example, I remember during COVID, we admitted this woman who had single mother, 5 children, poor and all that, and we kept her in the hospital because of her gendered factors, not because of her medical condition. So to make a long story short, we really need to start thinking about the people as a whole, and it's, the illness, but also the context in which people develop and deal with illness. So, I think interventions are to really, in those predictive models, incorporate, gender variables. Another intervention could be that, if we really want to push gender and sex in science, medical journals have to, insist that we will not publish your paper if you didn't do a sex disaggregated analysis. Clinical trials that did not measure gendered factors in order to understand why there's a response to treatment versus no response to treatment will not be published. I mean, it's time to be serious about it. Otherwise, it will continue like that. So I think, these are some of the kind of more, point of care related interventions. And the other is more of a, as a group, we need to insist on, we've done it with the, funding agency to some extent, which is great. But, to continue and to make it happen, it has to be like medical journal. I'm on the board of Health Canada, the Committee for Women's Drug and Devices. The FDA and Health Canada, they don't require sex disaggregated data to approve drugs and devices. I mean, they have to. I mean, so there's a level of advocacy that we need to continue to have in order to advance and lead to the well-being of our people in general, be them the various gender identity. Anyway, so this point of care, journals, and then, policy, we really need to intervene at all these levels.
Thank you. Paula, what type of interventions would you suggest? We don't hear you. I think you're muted.
Sorry. Yeah, so I think as Louise was saying, it's really time to act. And, one of the things that we noticed in our research is that people generally had data on at least sex and age. That was something that we saw in all of the work that we did. And so that's a starting point. But the whole gender piece, these important sociocultural bits that have such an important role to play are completely missed out. So, to me, I think, one of the places to start is that we do need to make sure that funders are asking, if you're going to do research, this needs to be planned from the start, that you should be thinking about, sex, age, the key kinds of intersections, and thinking about what are some of these sociocultural pieces that are really so important that we've heard mentioned, that we could address, that we should think about, that are currently completely off the radar. So I totally agree that I think there's a big role for funders to make sure that that's a requirement. And then I also think that, as has been mentioned, when you get into things like, we're looking at drugs, that's such an important issue. Drug development, there's no really requirements for anything related to those gender-related sociocultural type factors that ought to be brought in. So I think there's a lot that we could do by encouraging these key things to be included in research and also on the drug development side.
Thank you. So, yes, please, Rosalba. Yeah.
Just to add to what Louisa was saying, that it's important in the design phase of the study to involve patients. That was something that was mentioned also yesterday, because this is a not new, but is feeling important. The importance of this patient and public involvement in the design phase of the studies is very important also in this kind of problems, because we can incorporate into the clinical study design also patients' need and what patients feel about their disease and their needs about the outcomes also of the studies.
Mm-hmm. Yeah, we'll come back in a minute about this question of patient involvement, actually. Christopher, still about the possible interventions.
More on it?
Well, I mean, if you want to add anything to what has already been said.
Oh, in that sense, yeah. When I consider my experience maybe in the Scandinavian countries and how this has been dealt there, the aspects of enforcing some gender considerations into the management of tinnitus, I'd view that as eventually complicated, because the system is really dealt into having guidelines for people to adapt it, and it's pretty procedural. When you go to the GP, you have 10 minutes, not more. So it has to be quick and done like that. There's no room for those considerations, as you've been talking before, your circumstances, your life, your quality of life, your work environment, your family situation, that in other systems, maybe where you have more private care, you may have the room for these. So I think that the dissemination of those aspects within the community is really critical. And more we advance in the science and more we propagate this knowledge, that'll become more and more effective as well. Yeah.
Yeah, but if I may say, one place to intervene would be to incorporate those factors in the guidelines.
Yeah,
there are people who are kind of, there's
yeah.
hot spots of danger in terms of, so it might be one way to integrate the gendered factors in your system.
Can I also say that sort of speaks to the idea of the public health approach to some of these issues? Maybe some of the things we've talked about, like income, for example, or people who are unmarried, or whatever, educational attainment. Maybe it just speaks to the importance of addressing some of these things globally, because maybe they impact in many, different areas.
So we had a question over there.
Thank you. It's not a question, it's another point. I fully agree with all your points, but I think we should go to the bottom, and we should include this information and formation in the education at the School of Medicine, at all the schools of health sciences. Because if we still, without talking about gender medicine at the schools, usually the professionals are not aware of it. Then this is the first point that we can act before talking about research.
Thank you. Actually, I'd like to pick up on the point you started making, Rosalba, about involving patients. And I mean, participatory research has really been very important, and we have discussed it since yesterday already, and it's recognized as a very useful approach. Do you think that it could also address gender inequality, or maybe more in the light of participatory research? What do you think the strategies could be to capture patient perspective? I mean, we've heard of a few ideas already in some of the results yesterday, and you have brought in some, but how much further can we go? How can we involve them more?
Yeah, I think we should start from the design phase, because the patients should be involved also in what are the methods of research are. So I think the patients are never or almost never involved and are never aware of which are the research methods. And the example that was in my first slide is one of the useful example of an association of patients that is very active in involving patients in the comprehensions of what are the methodology of the science. In fact, they organize courses for patients in which there are some researchers that are showing their project, like ours, for instance, and are explaining all the methodologies that are used in those projects, in order that the patients can understand also the results, and then can also give their opinion on what about the outcomes the study could be, or also can make suggestions to the researchers about what is really worth to be investigated. So we could start for the design phase with focus groups, for instance, interviews to the patients. Also, when you design a website, it's important that is a website that is make to show that the project results is also, it could be useful to investigate which are the opinions of the patients regards how the information is conveyed in this website.
So involve patients, yes, from the design stage and websites. Christopher, is that your experience as well?
Well, I transiently moved from Sweden to Nottingham for a short period of time in the middle of COVID too. But this made me, this gave me a nice experience, because when we were there, any study design that was ongoing had to be involving patients. They call that the PPI, patient and population involvement, which I thought was very important and nice. But I saw high demands, in fact, on these participants to come at recurrent meetings, to discuss about, the strategies, the decision. It was a long process. We wanted to do a COVID study and evaluate how much it impacted tinnitus. And it took 6 months of long debates, and it required those patient representatives to come once per week. These people are working too. And if they're available, it's possible that some of these maybe are unemployed or more available than others. So it could cause a bias also in the study design. I would want just to raise that we have to think about it as well. It's a high demand on people to attend those sessions until, it's not only at the phase of the study design, you need to involve them up to the submission, even after interpretation of results. Do they need compensation? Questions, would women be more available than men in some countries than others, because maybe they have their kids and they want to come while the men are working? Difficult. That's quite...
A concluding question, unless we have a pressing question from the audience. No, I don't see any. So what's the next frontier in terms of research in sex, gender and health combined? Louise?
I need more coffee to answer that. I think we need to talk about precision medicine, precision diagnostics, precision healthcare delivery, precision public health. So obviously, you want to make sure that you provide the care to the exact person who needs it. So how do you achieve that, And the next frontier is to be able to put all these pieces of information together with large data, to arrive at precision health. But the truth is, that's kind of a maybe theoretical but the bottom line is that, social inequity lead to gender inequity. And, we need to fix society. That's the next frontier in order to improve health. I mean, that's the bottom line. It happens, in policies, it happens in dealing with, homelessness and poverty, and that's the source of all the problems. So we're in our ivory tower, talking about variables and all that, but we need to be able to influence with our knowledge, policy and social policies and all that. That's the next frontier. We know what it is. It's nothing very, high level.
Paula, would you agree with that approach? Fixing society? Very ambitious program.
Yeah, pretty ambitious, I guess. I guess one of the things I think for the sort of the next frontier is it's sort of the idea that you don't know what you don't know. And I think, by having people start to think about the importance of thinking of key things like sex, age, gender-related sociocultural variables in all the work that you do, you start to see patterns that you didn't really see before. And I think it does point to inequities, really important inequities. Our work, inequities related to older people and inequities, especially for those who are women. And it just points out the importance of why you need to look at these differences, because once you see them, then maybe there's an opportunity to start intervening. So for me, it's the next sort of pieces to make sure that people are asking the questions really and getting the data so that we can actually see where some of these inequities currently exist.
Christopher.
Yeah. For me, that project was an eye-opener. And now that this is closing, I'm reflecting on it, and I see, in the majority of the data that we've been handling, the definitions were based on sex. And not even, it was always a binary situation. And the work that you've been doing was to put this gender dimension into all those existing data sets. But it's still a binary definition. And when I've been discussing with people about our work, I see layers of nuances. Gender, it's possibly how you perceive yourself, but also how people perceive you. So it's your representation, how you feel you are. Are you more male or female? Or people, do they perceive you more as male or female? Women, men. But then there is also potentially the influence of the sexual attraction. Are you attracted to the same gender or to another gender? And so there is like, I'd say, a kaleidoscopic view suddenly of the gender definitions that maybe not be captured by just a binary definition. And this is where I think it may go in the future, because we're talking about minorities as well that haven't been highlighted, at least in my project, enough.
I want to maybe qualify a bit what I said, but the opportunity that's happening here is really like, it's a new science, that we're developing. Like the sex and gender science. I mean, we spoke about gender a lot. Your project is really like sex, all the biological, biomarkers, genes, and huh? No, I know, but I was not finished. But then you also have the gender-related factors. So the next frontier, like there's a schism between, basic science and biology and all that, and then the social science. And this is an opportunity to put them together. And they do operate together, in terms of, causing disease and, again, accessing healthcare and dealing with it. So I think that the next frontiers is new science that we really need to push. And it is, about precision medicine, but this is a great opportunity, and I think it's the beginning of a new science. So just on a more positive note, aside from fixing society. Yeah.
Well, fixing society is positive. It is just huge. So, but thank you very much. So these will be our concluding words for this round of discussion. Thanks very much for your questions. Thank you.